Okay, so we're going to go into the last part here. And Pat Emsellem. Pat Emsellem has been Chief Operating Officer at STAR in Star of Rhode Island for more than 30 years. She has an MS in Health Services Administration from Salve Regina University. Okay. Is a licensed alcohol and drug counselor and has presented at numerous state and national conferences, as well as in Russia. She was an advanced practice fellow in a U.S.-Russian social expertise exchange around use of mobile health technology to improve treatment outcomes for high-risk women. Since coming to STAR, Ms. Emsellem has been acutely aware of the challenge facing the loved ones of people suffering from addiction. Recognizing the value of the ARISE approach, since 2011, she has spearheaded the expansion of ARISE-based services at STAR. And the name of this presentation is Implementing ARISE Based Family Services in a Nonprofit Addiction Treatment Agency, STAR's Experience. Okay?
Thanks, John, and good afternoon. This has been a wonderful conference. I'm so honored to be part of this esteemed group of presenters, and thanks to the Grubin Foundation and Diana, to Newport Hospital, and to Salve for sponsoring it and for including us in the program. The other speakers came from the Netherlands, London, Colorado. I came from 8 blocks away. So being here at Salve, as you heard, I got my master's here at Salve about 20 years ago, so it's really a treat to be here at Salve. Also, my daughter is the library director. She here at Salve, so, and I think she snuck out of work to come over here because she helped me with this yesterday. So, also in Newport Hospital, I feel a connection to Newport and a warm spot in my heart because my 3 grandsons were born at Newport Hospital, and there were some crises, and they took such good care of my daughter and the babies. Here, let me get used to this. All right. There we go. So Dr. Landau has given you the details and some of the theoretical framework of the ARISE model. I'm going to describe our efforts to operationalize the model at STAR. I've been Chief Operating Officer at STAR, as John said, for 32 years. And although we've grown to become an integrated behavioral health primary care organization, we started as a detox back in 1977. So that's been our core mission. But now we have, in Fall River, we have a range of programs on our campus in the Highlands section of the city. We have a 74-bed inpatient building that has detox, dual diagnosis detox, and a short-term residential program of about 21 days. We have a range of outpatient services, and we also have a federally qualified health center with 50,000 patient visits a year. In the south end of the city, we have a satellite site that's the methadone clinic and another primary care site. In Rhode Island, we have Starbirth, which is a residence for pregnant and parenting women and their children. And for 20 years, we ran the detox network for the state of Rhode Island for the uninsured. So that facility, we don't have that anymore. It was sold in 2014, but that was what we did for 20 years until pretty much the Medicaid waiver changed it because there weren't uninsured, hardly any more uninsured. So the payment mechanisms changed. So the focus of our ARISE services has been the Fall River community, which is economically depressed and culturally diverse. 26 of our residents were foreign-born. That's double the national average. About half the population is of Portuguese heritage. And most of our revenue comes from Medicaid-based fee-for-service. The funding sources and target population are relevant when talking about operationalizing ARISE because we don't have the same incentives as private treatment facilities that have adopted ARISE and other intervention types of services. So helping families get their loved ones into treatment through ARISE greatly benefits the addicted person and their families. But for the private system, interventions also keep their beds full and keep them financially viable. In the public system, we never need to market. We never have enough beds. That's always the case. So the business case for implementing a program like ARISE, they're really different in the publicly funded system. In this hour-long presentation, we're going to share our experience with implementing ARISE at STAR. I'm going to give you an overview for about 30 minutes, and then each of my colleagues will talk to 5 or 6 minutes, sharing stories about how ARISE has impacted our patients, their families, and describe where we're going next with integrating ARISE-based services at STAR. And we've planned some time at the end for questions and discussion. So the underlying theme of this presentation is change, and that's why I love this work. That's why I'm still working. I know there are days when maybe the change is not so appealing, but for the most part, I love seeing people change, I love seeing families change, organizations change, system change. And maybe because I've been around so long, I have a lot of hope for all of those things to get better, and I guess I like to be somehow a part of that. And so I think for this, what we're talking about really is changing individuals, changing families, changing provider practice, changing the organization, and changing the treatment system. For us, ARISE was a powerful tool to help us get reluctant patients to enter treatment and help them stay in treatment and recovery. That power is derived from helping their family change how they react to the addicted loved one. Once we were persuaded of the value of the ARISE model, though, we needed to effect change in how our providers practice. And this is a central challenge for all of healthcare, translating research to practice. Science shows what's effective, and yet getting providers to adopt it, there's a real lag time of maybe a couple of decades at least, maybe more. So how do we help someone who doesn't want help? And that's the central challenge. Anybody who works in the field knows that you're always running into people who have loved ones who have an addiction, and they're desperate for help, but the loved one isn't ready to change. Data from the National Survey on Drug Use and Health indicate that only 1 in 10 of individuals needing treatment are receiving it. So certainly a shortage of services and access barriers contribute to that. But a significant part of that underutilization of treatment is that people with serious substance use disorders don't always want help. In a survey of child welfare workers, who were asked about barriers to getting parents into treatment for addiction, 86% said the parents' lack of motivation was the most significant factor. In the 80s, Prochaska and DiClemente, who happened to be URI professors, came up with a very useful framework for understanding individual behavior change. This stages of change model, the trans-theoretical model of behavior change, has profoundly influenced behavioral health services, the larger healthcare field, and is part of the knowledge base for design of health technology, such as mobile apps and other forms of connected health. Understanding the stages of change promotes acceptance of our patients. Meeting the client where they're at led to the harm reduction model and strategies for enhancing motivation to change. Among the main strategies for enhancing motivation to change is motivational interviewing and mobilizing the family and social network. Research shows that few people with substance use disorders enter treatment without pressure from their networks. Mobilizing the family and social networks significantly improves the chances of engaging addicted individuals into treatment, persuading them to complete it, and encouraging them to strive for long-term recovery. So while we were looking for an answer to the problem of motivating addicted people to enter treatment, we learned about 3 models. The Johnson model, and this is the model you see on TV, the intervention, it usually involves a sort of gotcha moment, a surprise confrontation with the loved ones, and some research has suggested that that contributes to some disruption in the family relations that can be lasting, and also sometimes the patients don't stay in treatment that long because of the just the way that was handled. But that's been sort of the standard in the field in the past. The Kraft model has been shown to be effective in changing families and motivation for treatment. It's a motivational model of family therapy that teaches the family skills that more effectively move their loved one towards treatment, reduce substance misuse, and improve their own lives. Given the cultural characteristics of our target population, many are not accustomed to or open to mental health services and therapy. I mean, it's just foreign to many people and cultures. Also, there's a shortage of master's level clinicians who really understand and are experienced in addiction, and who are also very effective in working with families. I mean, they may be out there, but when we've advertised, we really don't get applicants who have that kind of experience. So the fact that the Kraft model tends to rely on clinically trained people is a barrier from our point of view. We find that the people who are really talented at working with families often don't have that credential, and one of the great things about Arise is that we're really able to harness the power of those people and how good they are at working with clients and families. So you've heard about Arise. It doesn't require the family to commit to participate in a series of family therapy sessions. It's strength-based, destigmatizes addiction, and has been shown to be equally effective when implemented by non-clinically trained and credentialed interventionists. Arise seemed like the best fit for our agency. When I started at STAR as COO in the late 80s, commercial health insurance was paying for 30 to 90-day stays at the private treatment facilities such as Edge Hill Newport. These facilities paid marketers who were embedded in communities throughout their primary target area. Usually they were in recovery, they were really tied into the recovery community, and they'd been trained to do the Johnson model. Those programs had a strong family component that included education support and encouraged family change through participation in community-based self-help such as Al-Anon. With the advent of managed care in the 90s, many of these programs went out of business, leaving communities without access to family intervention services. Meanwhile, states were directly funding addiction treatment services for the uninsured. In Rhode Island, initially, it was Benjamin Rush, a state-operated detox facility. From the mid-90s to 2012, Rhode Island contracted with STAR to provide detox services for the uninsured at our North Kingstown facility. And in Mass, the state contracted with nonprofit community-based organizations throughout the state to provide detox services. Beyond an occasional family treatment planning session, though, family involvement has not been a key component of publicly funded programs like ours. And yet, we as providers were continually confronted by family members desperate for help for their addicted loved one. When family members called our detox admission line, our response was, there's nothing we could do until the loved one called for admission themselves. We said things like, he needs to hit bottom first, or maybe he hasn't done enough pain. We needed to change, especially with the opioid epidemic. It's particularly in the last 10 years, and as fentanyl has become more prominent, we are losing so many of our patients who were in and out, had periods of sobriety, came into treatment, and then may have relapsed, and brief relapse and they're dead. We have lost so many of the patients that our staff had been attached to. So, when you talk about trauma and grief, it certainly is affecting our staff, and we're always looking for ways to help them process this. But so bottom line is, that's not an acceptable response. So we needed to change our organization. We had to question some of our assumptions about our patients and their families. People in our field generally believed that families that want to help their loved one are codependent. Their involvement would be harmful to the recovery process. Yet, research shows, and we learned this from Judith, shows that family members can learn how to support their addicted loved one and heal themselves, and that engaging the family can be a powerful tool in helping move the addicted person more quickly to the action stage of change. We also believed that our patients were not connected to their family of origin. They'd burned their bridges. Research cited in the ARISE training indicated otherwise. One meta-analysis of research on families of drug addicts showed that 26 of 28 reports found drug addicts to be in regular contact with one or more parent. 90% of 22-year-old New York narcotic addicts returning from treatment lived with mother if alive. 86% of 25 to 30-year-old opioid addicts saw one or both parents face-to-face at least weekly. When I heard about this research, I have a lot of confidence in Judith, but I still questioned it. I was skeptical because that was so different from what we believed and what our patients told us. So I remember working at home on a homeless grant application, and I called Ron, the lead counselor at the North Kingstown Detox, and I asked him I didn't want to quote this research if it didn't really apply to our population. So I wanted to have him pull together a focus group of his current opiate addicted patients who had identified as homeless upon admission, and ask them specifically whether they were in touch with the family of origin and to what extent. All but one were in regular contact, and also said they believed they would be able to live with a family member if they and the family member had hope that their addictive behavior would change. So we decided we wanted to implement ARISE, and we used it in two ways. Pre-treatment, helping the person, mobilizing the family to get the person into treatment, and then we used it for patients who had difficulty staying in treatment but were already there. So some of us would call that a reverse intervention, but so we had no funding for this, but we started by getting a workforce training fund grant to train our frontline workers, many with lived experience in personal recovery or family recovery. We trained them in the ARISE model. And the results of that first group was really pretty exciting to us. Almost 80% of the addicted individuals went into treatment, most of them pretty much right away, but also 55% went on to a second level of care. And that's been also a stumbling block. You get people in, but they don't stay. So that's a really important measure of success. So Linda Cuttino, who you stay, not yet, who provided the Arise intervention services to some of these families, is on the panel and will tell you about one of the families shortly. So we were very excited by the results, and we wanted to change provider practice to more meaningfully engage families and integrate the Arise approach into our treatment services. So at STAR for a decade or more, we've been using the NIATEX model of process improvement. It's a rapid cycle process improvement model that we learned when we were part of a national initiative funded by Robert Wood Johnson to increase access to treatment without increasing cost or resources by reducing waits and removing access barriers. And they taught us this model of rapid cycle process improvement, which we then adopted and used for organizational change. So in 2012, we convened a change team, and the goal was to reduce the AMA rate on inpatient by increasing family involvement. So the change team met, and we wanted to reduce the percent of detox patients who leave treatment early. And we decided, and that's really an important measure, as I mentioned, that length of stay in treatment is one of the strongest predictors of positive treatment outcomes. So we picked our first intervention was to do a pilot project with 11 of what came to be called the frequent flyers. But these were the patients that came in frequently to detox and then would leave right away. And staff was really frustrated at our inability to help these patients. I mean, we always have hope. We always take people back because you never know when it's going to change. And certainly we've seen examples of people who had 30, 40 detox admissions and finally achieve a long-term period of sobriety. So we always have that attitude that there's always hope and we always take them back. But we certainly weren't having much success with this population, and we were seeing some of them physically deteriorate. So we were worried, that things were beginning to seem more urgent. We needed to do something. So these also were patients who told us, I don't have anything to do with my family. They're tired of me. If we asked in the beginning, do you want to involve your family? They always said no. Well, STAR staff noticed one of these patients pointed out that his sister was bringing him cigarettes twice a week. So we realized that it was how we asked the question and what our expectation was. So we identified 11 patients who had multiple admissions over a couple of years, who also said they had burned their bridges and weren't involved, didn't have family involvement. And we approached them differently, and they agreed to have somebody contacted, and that the loved ones, various numbers, but loved ones did agree to convene, and they became involved in Arise. So we were amazed. I mean, it's certainly a very small group. This isn't scientific, but nevertheless, these were patients we knew and whose staff felt pretty hopeless about. And 80% of them finished detox. But not only did they finish detox, they went on to a second and third level of care, which was pretty amazing. So we were sold. And I think that that also was a powerful influence on our staff, too. When you talk about research to practice and the slow adoption, it's because people don't believe it. And, maybe it doesn't fit with their experience, what the research says. But when they see it, and they see it in patients that they know, and they see them get better, you get a much greater adoption and support for the change. So next we looked for a way to get more of our patients' families exposed to Arise. We wanted to involve families in an Arise-based family education and support group. So that was our second NIATEX intervention. And again, this was something we had tried to do before without success. So we had tried for a couple of decades to start a family education program for the families of our patients. But this time we put a couple of our most effective ARISE interventionists in charge of it. They had lived experience, and one had close ties to the Portuguese community. They also knew the families who had participated in ARISE or inquired about ARISE, but had not yet been willing to actually initiate an intervention. So, the personal characteristics of the group leaders certainly contributed to the success of recruiting families for the group. But also, many STAR employees were now aware of the successes associated with our ARISE efforts, and they provided referrals and warm handoffs to the ARISE Family Support Group. The group's been very successful, and it keeps growing. I mean, it's definitely outgrown the room it's in, but and the group leader, whom you'll hear from as well, and she'll tell you some stories about the group. She keeps bringing it up, and they all refuse, so they're not willing to split up. So we're going to start another group and hold it at the maybe at the hospital in hopes of attracting maybe another population. So with the success of the interventions and the availability of the family support group, we wanted to more fully integrate ARISE and families into our services. So without a source of fee reimbursement for family interventions, especially those provided by somebody who's not clinically credentialed, certainly you can, if you have somebody who's a master's level clinician, you can bill insurance as therapy. But we have a shortage of those, and we also find that many of the non-credentialed staff are really highly effective. So we like to harness the power that they bring to us. So we had a community support program, and that CSP program was the precursor of our recovery coach services. And we decided to focus on them because they could bill for that. They were billing case management 15-minute units, and that did include contact with families. So that seemed like the most practical group to start working with in terms of increasing family involvement. So we provided, Dr. Landau and Sarah came to do a training. So we did an ARISE intervention training series on site for the CSP workers. And after that, Dr. Landau's colleague, Jim Garrett, came from Albany every few months to continue the training and supervision and sort of support people. I mean, they did role plays on how to get the patient to agree to engage, have the family engage. So, and how to overcome the resistance, practical things like that. So we really were focused on it for a while. And we wanted to try to institutionalize family involvement with that group by giving them data. So collecting some simple data that we could show them and just kind of monitor and compare progress and look at the trends. So every month the CSP workers would turn in a sheet that indicated how many of their patients had some significant family involvement. And then we'd give them feedback. Quarterly, we'd give them a report that told the aggregate caseload with family involvement and then their own individual one. And you can see it was not easy to sustain. So we started collecting the data. I think maybe we did the first training in, a couple of months before, and then we started collecting the data in February. So I would say probably before we started, it would have been closer to 0, but we didn't have a baseline. So you can see in February, and then March it got better, and April, and then it starts to fall off. And it's kind of like there are so many barriers that come up. Our trainer unfortunately got sick and later died, and we were very attached to him, and it really and with staff turnover, it really needed a focus at the top level, and to sustain that focus, since, you know, it wasn't like we had enough people to kind of keep the momentum going. So there was no external structure to keep this going. It had to be internal. And, you know, things come up. Crazy things happen, and we lose focus. So that was not a significant change over time. So one thing we realized from that is that we need to work on changing the system and changing reimbursement so that there are external structures that support meaningful family involvement in publicly funded addiction services. Interventions aren't covered by health insurance because it is pre-treatment, and the Bureau of Substance Addiction Services, and I'm talking about Mass because that's where most of our services are. You know, Fall River is not far from here, but if you live on the island and you don't leave the island, maybe it seems far away. But I can tell you that the drug dealing pathway is very closely aligned between Newport and Fall River. So in Massachusetts, the Bureau of Substance Abuse Services funds and licenses addiction treatment, and they've been supportive of ARISE. The BSAS director heard about it during a visit to STAR years ago, and he was influential in targeting some grant funds to STAR to implement ARISE. And they also funded Brandeis to evaluate it, which Dr. Landau mentioned in her presentation. And as a result, the BSAS created a new funding mechanism to support family intervention services. However, the way they did it made it hard for new agencies to jump on board. So, you know, it pretty much stayed STAR in Gosnold, and we tried to involve another agency up to partner with them, and they were very gung-ho. Dr. Landau did some training for them, their medical director, everybody was excited. But then they couldn't get it paid for because they didn't quite qualify for the BSAS funding. So that went by the wayside. So the funding, the BSAS funding, with the leadership changes at the Bureau of Substance Addiction Services and the Department of Health, we kind of lost our champions, you know, and the people that are there, there's only one person who really knows what this is about. And so it's become less important, and as they change reimbursement strategies and so forth, they have become less aligned with the way that our ARISE service is delivered. So we are operating at a deficit, and that is putting us in jeopardy. So we're looking at other ways to do this, though, so workarounds, and one of the things we're doing, which is not just because it's hopefully a new funding stream, but because we feel this will meet a need that we've identified among our families for a family peer recovery coach. So we have a federal grant that will allow us, and that's not the focus of the grant, but it's one of the initiatives that's going to support the development, the training, and service design of a family peer recovery coach service. And Aaron Brett, the grant coordinator, and also John Brett's son, is going to tell you about that initiative in a few minutes. So just to share with you and summarize some funding strategies for these services in the public system. Certainly workforce development grants are out there these days, particularly for the addiction field. So you can get people trained with a workforce training fund grant. And then you can also look at ways, like we did, of incorporating the family services into already billable service types, such as CSB and recovery coach. Another thing to consider, I mean, this isn't probably reality today, but the improved treatment outcomes that result from these family involvement initiatives can be offset by shared savings when operating within a value-based payment structure as envisioned under federal health care reform, and this process is well underway in Massachusetts. So I think sooner rather than later, that might be an option. We can prove that it saves money for the healthcare system, and therefore it gets funded. So in addition to funding, there are regulatory factors that impact families trying to help a loved one with a substance use disorder. In Mass, there is a somewhat controversial legal provision, Section 35, that allows families, police, healthcare providers to petition the court for civil commitment due to a substance use disorder that renders the person a threat to themselves or others. And it's not so much controversial among families, it's controversial among the payers because people use this to get into treatment. And so there's really a proliferation of Section 35 inpatient programs. And the Bureau has said that it really would make more sense for these families to use an ARISE intervention than it does for them to petition the court for civil commitment, because, you know, they're also really surprised and disappointed after they go through all of this. I mean, it's really humiliating for the person. It's in similar effect as say, the Gotcha Johnson intervention, but more serious, because the person who's been, the court has ordered the civil commitment, they have to be transported to the treatment facility in the sheriff's van in shackles. So that is a really sort of unforgettable trauma for both the family and the patient. So it's not the best, but it's widely used now. And then in a sort of full circle from the 90s move to managed care, a couple of years ago, in response to the opioid crisis, the Massachusetts State Legislature enacted Chapter 258, which mandates insurance to pay for detox and short-term rehab. So with few exceptions, the insurance company is not allowed to deny admission. So that was sort of a sea change in terms of legislative support for treatment. So anyone advocating family involvement in addiction treatment is aware of the federal confidentiality laws, sometimes referred to as 42 CFR or the Part 2 regulations. 42 CFR predates HIPAA and has much stricter prohibitions against disclosure of treatment information than does HIPAA. So treatment center staff have been trained, they're trained every year, they have to be trained in 42 CFR. And they're told that when someone calls asking about a patient, unless they have a signed release from the patient to speak with that person, and the patient can withdraw that release at any time. So they may have had one when they came in, and 5 days later they may say, no, you can't talk to my mother anymore. That the staff are told to say, we can neither confirm nor deny whether the patient is in treatment, no matter who the caller is, whether it's police or public official or family. And there's good reasons to be more aggressively protective of the privacy of people seeking help for addiction. But families will be understandably frustrated by hitting this brick wall when reaching out to a treatment facility. So one of the benefits of having an ARISE interventionist or somebody from the family program is by helping them understand and navigate the treatment system's legal and regulatory complexities. For example, we can inform them that while the treatment agency may not be able to tell you anything, and this is why they may not be able to, you can tell them anything you want. And a lot of times, that's real, that does a lot for them, because even though they call and the nurse on the detox says we can't confirm or deny, but she says, you know, I'm so-and-so's mother, and I want you to know about this because I know he's not going to tell you. So sometimes that in and of itself gives some sense of relief because you are connected to the caregivers. But those are the kinds of things that, I don't know, people just wouldn't be apt to know. I mean, it's complicated. As hard as we all try to remove access barriers, there are always unexpected complications. So, you know, I mean, I think I know as much as most people. But I tell you, you can't manage your way through this system without somebody, I think, without somebody holding your hand who really knows the system and will stick with you. And that's sort of what Recovery Coach is. And for the families, that's what we want Family Peer Recovery Coach to be. So our involvement with families has also made us more sensitive to what it's like for families. And to the extent we can, we've adjusted our priorities with changes to our practices around notifying families when a patient leaves treatment. So we used to be more strict about it, but strict in the sense that our interpretation of an emergency, right, has broadened. So if they sign a release for an emergency contact when they come in, which most of them will, but you don't have the authority to contact unless it's really an emergency. Well, now with the opioid epidemic and fentanyl and all the overdoses, if somebody leaves, in most cases, we're defining it as an emergency. And if it seems appropriate, you know, the families involved, we let them know so that they could maybe help intervene and, you know, catch the person. Catch in the broadest sense, catch them from falling. In this presentation, I've talked about adopting ARISE family engagement strategies at STAR, how these efforts impacted the individual behavior of the person with the substance use disorder. I've talked about changing provider practice, how organizational changes were needed to support family involvement, and how the influence on and from the larger treatment system affects success of family involvement strategies. What the addiction treatment system learns about mobilizing families to enhance motivation and behavior change has important implications, and I think Dr. Landau has talked about this before, maybe a little bit today. But just as the recovery model began with the addiction field and has now been adopted at the federal level as the framework for mental health services, family engagement to motivate behavior change may start with addiction, but could be a game changer in primary care, where the leading causes of mortality and drivers of healthcare costs are associated with modifiable behavioral risk factors, such as smoking, diet, and exercise. So I'm going to turn now to our panel. Our first panelist is Linda Cuttino. Linda wears a number of hats at STAR. She just happens to be our HR director, but her passion and talents for working with families has led her to assuming the leadership role for the ARISE services at STAR. She's a certified ARISE interventionist, certified ARISE supervisor, and she's going to tell you the story of one of our ARISE families.
Thank you. Good afternoon. Oh, excuse me. Nice way to start. Good afternoon to everybody, and I have to say I'm very honored to be asked to speak here about ARISE, especially following these amazing people. Hope I can do as well. So I'm going to talk to you about a intervention family that I did way back in 2007 when I was first trained in the ARISE intervention model. But first I'd like to give you an idea of what it's like for families to come in looking for treatment for their loved ones. I, unfortunately, have lived experience because my husband is an alcoholic. And I'm not nervous, but my voice is very shaky from my cold, sorry. So my husband, I was at wit's end. I didn't know how to help my husband. No matter what detox I called, they couldn't help me because they needed to talk to him. And he was so drunk he couldn't talk. And so I would end up at hospitals, and then he'd have to get medically cleared and wait and be sick and go through with withdrawals. and finally probably get medicated an hour or two later. He was even put one time into, what do we call that, a tank? Like the drunk tank. It was like 6 people that everybody smelled so bad because they were drinking and everything and hurting so bad, and they were all stuck in this little room. It was just pitiful. It was horrible to watch. So thankfully, my husband went to 13 detoxes, and he finally found recovery. And today, he's got 20 years in recovery, and we have a much better lifestyle. And I'm glad to say we got to jump off of that spinning merry-go-round. So, and then in 2000, I feel like that made me make a decision in my career, and I joined STAR. It always interested me to work with addiction because of living it, and I got to do that, and I just lost my thought. So, and like the family piece was very dear to my heart, and I trained as a front office manager when I first came, and I then was doing intakes, the calls from the patients calling in to get into treatment. And I was one of those people that had to say, I'm sorry, I can't help you. And that was just gut-wrenching to me because I lived it myself, but I would give them some tips and say, go to the hospital, but go to this hospital, do this, do that. And it was so, I couldn't believe when we found out that we could do a RISE intervention at STAR. We found out when we were at a conference in Florida, and it just meant the most to me because we could finally help people and, and treat families with dignity and help them through all of this. So, let me see. So back in December of 2006, after our first ARISE training, we had asked some of our frontline staff to come to the training so they could understand how ARISE works and how we were going to go forward with the process of getting an interventionist for these families. And during that training, one of the intake people was talking about the challenge it was to talk to families that were trying to help their loved ones and how chaotic some of them were. In one case, there was a very upset Haitian woman that spoke Creole, and she had called before and was told that she couldn't, we couldn't help her, that the person had to get on the phone. And in this case, so she was talking about all that and how hard that was to do. Well, then about 3 weeks after, when we put the process in place, this same woman called back, and she remembered, and she was crying. She was very upset. There was all screaming and yelling in the background, and she put her son on the phone because she knew she had to do that. Well, he was so angry, and he started swearing and yelling. You could hear all kinds of craziness in the background. And he hung up the phone. And we believe it was the same family that called back like 3 times. And so I'm sorry, so I just mixed that up. So that's what happened when we didn't have the process in place. Then 3 weeks later, the process was in place. The woman called back and said, I need help with my son. I thought he was dead. He was laying in his bed, and he looked like he was dead. I need to have help now, or he's going to die. And they were able to tell them about the ARISE process and that they would have an interventionist call them within a couple of hours. So I was the interventionist that got that call. And I called them a couple of hours later, and I talked to this very wonderful Haitian woman that could speak pretty good English, and she was just so happy to finally reach somebody that could help her and her family. That because we do a lot of our ARISE work on the phone before we have the actual meeting. So I was able to construct a genogram with her, and we went back like at least three generations at that point. And we did a recovery message. I know you haven't heard about that, but It's a few sentences that really tug at the heart and would mean a lot to the person of concern, the POC. So we did that. We talked about people who was going to come to the first meeting and got that all set. And then there was screaming and yelling again. The POC fell down and smacked his head on the floor because he was sleeping. He woke up, fell down. Everybody was in a panic. The 34-year-old daughter took over the phone. The mother was helping the son. I asked if they needed an ambulance or, things settled down. It calmed down a little bit. We set a date, which was that following Monday. This was a Friday. They couldn't do it on the weekend. So I just kept talking to them to make sure they took him to the hospital if they needed to do that because he was in bad shape and very drunk. So Monday comes, and I'm going to take a sip of water. Thank you. Of all times to get a cold. So, thank you. That changed a little bit. So Monday finally came. I had phoned their home to verify that they were still coming and make sure he wasn't in the hospital and all of that. And the mother reported that her and the daughter would definitely be there, and they were hoping the POC would show up, but they weren't sure. And I said, well, remember, you need to come. Even if he's not coming, you come, and we go forward with the meeting. So at 3 o'clock, the mother, sister, and the POC showed up. He was so intoxicated, so shaky, disheveled, but he was able to go through with this and sat in the chair. He listened to his mom and sister talk about how concerned they were for him, how worried they were, how many times she thought he was dead just by the way he was lying in the bed because he was so drunk. She would have nightmares and see the funeral procession go by her house. I mean, it was horrible. But all this convinced him to go. They had brought a suitcase in the car with them. He said yes. I walked him right over to the detox, the family and the POC, and he stayed there for treatment. I went over to visit him. He had gone to another detox once from a hospital, and he didn't even make one day. And he bought liquor that day and got drunk, and this was only a second try. So he stayed, and we had the second meeting when he was still, I believe he was about to go down to SOAP step down. And more families came this time, which, strength in numbers, right? So more family came. His mom and sister, of course, came. His estranged wife, his 12-year-old son that they had together, his godfather and uncle. Almost the whole family lives together. There were like 10 people that lived in that household. So they all came. He thought he was going home with them, but he didn't. And I think it really helped that the son was there and made him realize what they were all going through, and they told their stories. So he stayed, and he ended up, so he discharged 7 days later from the SOAP program, routine discharge, and he did really well. So we had another meeting that day, and the mother, sister, girlfriend, POC's son, and the POC's counselor came. He had 51 days sober at that time, for the amount of time that he had stayed there. In the meeting, we discussed the importance of continuing his aftercare plan. The POC and family expressed gratitude towards STAR. They believe that the intervention process really saved his life. He never went to meetings before, but while on the SOAP program, he found that he liked AA and NA commitments on the unit, and also going out with the SOAP clients to Sunday morning AA meeting. He liked the spirituality part of it, and he reports that he has now been going to meetings, not many, but some. He reported that he learned how to, I loved this. He was so excited telling the mother, that he learned how to cook eggs on the unit because we had a stove on the step down and we let them cook breakfast certain days. I don't think we do that anymore, but we got more fancier since then. So he was able to do that and learned how to wash clothes. So he washed his own clothes. He started washing clothes for the family. So that was like kind of a job because the mother was aggravated that he didn't have a job. And we talked about a get well job, maybe like Dunkin' Donuts or something. But when I had talked to them at the end of the year, he was just doing side things for the family, cutting grass, things like that. And he was having some medical issues as well. But he was still looking forward to going back to school, to college. And he currently is still not willing to go to outpatient counseling, but he's still doing his 12-step. And the family talked about trust issues, and I told them that they could use Al-Anon and explain that they were still on this merry-go-round that I hate. The POC got off because he got treatment. I said, but the family's still on the merry-go-round, and you are in need of treatment to help deal with the feelings of guilt that they always talked about because they couldn't trust the POC still. So they were looking at that. So before the year was up, the POC did relapse, and he called me, and he said, Linda, I relapsed, and I know if I don't call you, my mother's gonna call you, so I just figured I'd come in, okay? So he came in, and he got right back on track, and then I did check with him a year later, and he was doing well. So, thank you.
Thanks, Linda. So Marie Pelletier is also a certified ARISE interventionist. She's a certified ARISE supervisor, a recovery coach, and she leads the family group at STAR. She's also the one that pretty much all the time has the ARISE hotline, so she answers the call.
I have to put my bifocals on, I can't see. So thank you for having us. I'm going to talk about a family, and one of my babies is the family support group that I am very proud. I'm also proud to be an ARISE interventionist, but I think the family support group and the ARISE go hand in hand. It just funnels down. So this case will show how one particular family came in and looking for resources, and how ARISE led the way. Also, I'm going to piggyback on Pat. Our staff at STAR is educated on the ARISE program, the family support group, and when families comes in, they give them an envelope with all flyers from ARISE, flyers from the family support group. When they feel that the family is in crisis, they will call the hotline, which I have most of the time, 99% of the time, and ask us to come down and speak to the family. And this is what happened with this family. Family came in to open access looking for services. The family was blindsided by the POC's addiction. You wonder how they were blindsided. Well, their situation did not fit the addiction. It was stigma. They lived in the suburbs. Money was no object. Father made a lot of money, but father also traveled and worked in different countries, and mom went along with him, so there was family missing in the house. The son had the addiction for a while, but it wasn't until he went to college, that different state, alone, mom and dad were in Europe working, that his addiction escalated. And so he could no longer hide the addiction, because now he was not finishing school, he was homeless in the state that he was in, and so he had to come home. After sitting with the family, and then also another thing, the family was also like saying, there's no money missing, there's no objects missing, how can this be? Well, he had other resources to get money for his drugs. So after sitting with the family and explaining the ARISE model, and the family was on board and wanted help. So an interventionist was assigned to the family. They met within a week and had the ARISE meeting. And when I went to meet with the family, I also recommended the family support group. The Arise program is a wonderful family, involves the whole family, but we know that the families all need individual, that it's just for them. So, you know, their energy is so focused on the individual that they forget about themselves. And then when they're in meetings, they also can't say or express how they feel certain times. So, let me see, back now. So the family support group is, to me, a wonderful program. The first time I was asked to take over the group, I was like, shit, you know, it's at night. It's, you know, like I really didn't want to do it, but after the first day there, to me, it's my baby. And I try only when I'm on vacation to not attend. Even if I have a day off, I will, because the families are used to me. I know their stories. I can look at John and say, how's your son? And I can look at Mary and say, is he next door, and blah, blah, blah. So if you have someone else filled in, with times they have to, but they don't know the stories. And that's why Pat is absolutely right. Nancy's always telling me that I cannot have that many people. And it's not really lying when when she asks me, how many? And I'll say, 12, when it's really 19. I think it's 12. I never say it's 12. I say, I think it's 12, so she doesn't get, you know. But again, it's like, how do you split it up? How do you split people that have been supporting each other? The ones that have been going there for 3 or 4 years and are in a pretty safe place, help the ones that are coming in. So it's just like we work all together. It's just not me facilitating and controlling all those people. It's just everyone works together. So, like I said, the group is a wonderful resource and support system for all the families. They come in broken, hopeless, and angry. And I have one of our family members sitting over here who was so angry, she told me I could talk about her, so that's okay. So angry, she was sitting directly across from me, and I could see her with the arms like this, and the face, and just like, and when I have a new family come in, I say, you can just sit and listen. You don't have to say anything. If you need any support, you can stay after. And I kept just looking at her, and she was just like pissed off. That's her words, right? Pissed off and angry, because Kathy is in recovery for 32 years. And she was blindsided with her two children that were in the addiction process. But 4 years later, right? Is it 4 years? 4 years later, she's doing very well. Her children are doing well. She still attends the groups, the family support groups, most of the time. Only when she's in Aruba for 3 weeks, she doesn't come. But and now she's a part of the STARS family. She's working with us as a recovery coach. So it's a great. Not only do we support each other, but we educate the families. We make them stronger. We bring the addiction one-on-one and show them how the drugs affect the brain, so they could better understand what their loved ones are going through and their actions. We have speakers come in. We have people who have benefited from the RISE program and come in and share their stories. We have other agencies come in teaching them how to use Narcan. Families bring in flyers. Kathy's one of them. Resources for other things that are going on in the community, meetings, families recommending the Arise. We have about 7 to 8 Arise families that went through the Arise. Some of them still in the Arise, because like Judith says, we went from 6 months, but I have some that are going in 3 years. We're not always working with them, but if they need us, then we're there. Like I have a family, one of my first ones, she was in recovery for 3 years. And mother kind of drifted a little bit, but father comes every single week. Well, she relapsed. And because he was coming every week, and because we were still in contact, I was called, and happy to say that it was just like she fell off the horse, but she got right back on. The family was healthy, the family knew boundaries, the family was educated, they were supported by the family support group, and she's doing very well. She went back to STAR, she got, healthy, and now she's working, doing, it's like when some of the addicted individuals, sometimes they get a little cocky, you know, like, and this was her words. She stopped going to meetings, she stopped, you know, having a sponsor, she just thought everything was okay. And then now she says, now I know better. So this is a great resource, the Family Support Group. Am I done?
You're done.
I'm done? Okay.
Thank you so much.
I talked more than 5 minutes.
Thanks, Marie. And I'm afraid we've gone over, so I'm just going to introduce Autumn, and maybe if you have questions afterwards, you can ask these people. So Autumn's our LICSW, and yes, we have, our interventionists don't have clinical credentials, but you really need that backup, and so Autumn is our clinical backup. She's also an interventionist. And Aaron, John's son, I'm sorry, we should have put you first. So he's the grant coordinator, and he's sort of was going to talk about the family peer recovery coach. So thanks so much for including us in this, and I'm sorry we went over. So
mine's easy. We have grant money. We're going to spend it.